Hello friends, this is your friendly neighborhood pediatrician Dr. Aditya Bhatt, and as we discussed before about nephrotic syndrome, that the basics and the definitions of the disease. Now we'll go towards the management. So as we all know, please comment down below that what is the most common cause of nephrotic syndrome in pediatric patients, and what is the most common cause of nephrotic syndrome in adult patients. So there is a specific treatment protocol for treatment of nephrotic syndrome in pediatric patient. If it is a first episode of nephrotic syndrome, there is ideally 12 weeks therapy of prednisolone, where for 6 weeks we give daily therapy, and for the next 6 week we give alternate day therapy. Now if the patient improves, we stop the therapy after 12 weeks, because as you all know that there is very less chances of recurrence in pediatric patient. And those of you who have commented down below, the most common cause of nephrotic syndrome in pediatric patient is minimal change disease. So in minimal change disease, there might not be prolonged disease. So we only give for 12 weeks. After you complete 12 weeks, if the patient is either diagnosed as frequent relapsers or steroid dependent, as we saw in the definitions, then you have to give alternate day steroid therapy for long term up to 1 year to those patients. And the low dose steroid therapy, 0.3 to 0.5 mg per kg, we have to give for 1 year alternate day. And if the patient has infections or any stressors, then we convert it into a daily therapy. Now as you all know that there are complications of steroid therapy, long term steroid therapy. Please comment down below a few common complications of steroid therapy. So because there is a steroid there is low dose steroid, there is minimization of the complications, though there are complications. Now if there are relapses in the patient, then we have to shift to other drugs. Now if the relapse is uncomplicated, then we shift the patient to a drug known as levamisole. Levamisole is an antiparasitic drug, and it is given at the dose of 2 to 2.5 mg per kg alternate day therapy. The side effect of levamisole is agranulocytosis, and if there is a complicated relapse, then we shift the patient to mycophenolate mofetil. Mycophenolate, please everyone comment the mechanism of the mycophenolate mofetil, the mechanism of action of this drug. And if there is no improvement, then we use cyclosporin, tacrolimus, and if still no response, we shift the patient to rituximab, which is anti-CD20 rituximab. Now there is one drug known as cyclophosphamide, which is the drug of choice for the patients having steroid resistance. For patients having steroid resistance, though we prefer giving tacrolimus and cyclosporin before, the drug of choice is ideally taken as cyclophosphamide. The dose of cyclophosphamide is same as prednisolone, 2 mg per kg we have to give daily, but there is many side effects of cyclophosphamide, including hemorrhagic cystitis, and other complications of cyclophosphamide is severe bone marrow suppression and gonadal toxicity. So this is all for the treatment. I hope you like the new style. If you like this, please comment down below, and I will try to make more videos in this style. Thank you.